Okay, good afternoon, ladies and gentlemen, and welcome to the August Wye Valley Trust NHS Board. We, as you can see, are still having our board meetings digitally, but we're delighted if you're watching us live that you've been able to join us. In our board workshop this morning, we had 3 sessions, an absolutely fantastic presentation from our respiratory team and from all teams about the work that they had innovated and undertaken during the COVID-19 pandemic, which made us all incredibly proud and fully appreciate the agility, innovation and bravery of our staff. And I'd like again to put on record my thanks and the board's thanks for all of our frontline teams and the exceptional work that they have done and are continuing to do. And for their families and the way their families have supported them, thank you. We then had a session on the digital strategy for Wye Valley Trust, and that was an important development session. And then we had a session briefing us all on the care home sector in Herefordshire and the very real challenges that the care, nursing home and domiciliary care sector has had during the COVID pandemic. And again, we thank all of those care workers for their support of families around the county. We have a very full agenda today, so without more ado, we will go forward. Any apologies from absence? I don't believe we have any. Any new declarations of interest? Please come off mute. Are there any new declarations of interest? And the last set of minutes, is everyone happy with the last set of minutes? Please come off mute if you're not. On that basis, I'll sign the last set of minutes. Thank you very much. And therefore we move on to action points arising, which are page 16 of the pack, the digital pack. The first was that John Barnes will reflect information on theatre productivity. That's completed and within the report. Thank you, John. The second was that we would have a board workshop on end of life care, and we will be doing that in October. We would then have a board workshop on the IMT strategy, and we did that this morning, and we'll discuss it again a bit later. We then had the detailed response on the board assurance framework regarding risk 13. That was completed, thank you, Erica, and that's within the report. On the quality report, Lucy and Howard will review whether agency usage is reducing in comparison with reduction in our vacancy rate. That's completed in the report. And our agency progress has been quite fantastic over the last few months. So that's something which we will come back to, Lucy, in detail. On the capital plan, a visual update on the building, the replacement hutted walls, which are looking bigger by the day, I think it's fair to say. And well done everyone for all of their work there. We'll pick up on aspects of that a bit later. On the realising the group approach to leadership, board workshop is being arranged for September. At the last Foundation Group subcommittee, the work being done across the Foundation Group on leadership development was discussed. And I think it does put us at the forefront of developments within the NHS in terms of developing the talent and leadership across the Foundation Group. We then had Howard to review how typical the substantive medical staff additional payments are and compare these. That's being done across the Foundation Group, and Howard will brief us when that work is done. Thank you, Howard. Then the con teams to ensure that the message sent out to media to inform patients of the importance of staying on the waiting list and self-isolating. That's an ongoing action. So thank you for the team doing that. Are there any action points that I have missed? Okie dokie. So we will therefore canter into the Chief Executive's update report. Glenn, please.
Thank you, Russell. I mean, just on that final point, it's probably worth just picking up. There's been some more recent guidance from NICE, which is a bit more flexible in terms of the isolation of patients pre-procedure. So that should help with that issue that you just raised. Turning to my report, firstly the local outbreak which made national headlines, I just thought it was worth saying something about that, particularly actually how well it was managed by our local authority colleagues. We provided testing capacity to assist, but it was a lot of good work by the public health teams. Very complex set of circumstances. It didn't actually result in any admissions to hospital, and providing some really good local but also national learning in terms of how you manage such a complex beast. Secondly, the report from Baroness Cumberledge, which, as I say in my summary, is a pretty hard-hitting report, which is something that we will bring back to the board once the government has considered its response. It looked into medicines and medical devices safety and talked about institutional resistance in the NHS to patient safety concerns. So very worrying national headline. I'd like to think it's different locally, but there will obviously in due course be a government response which may have implications for us and particularly Quality Committee. So we'll bring that back as and when. Then talk about the two AGMs that have happened so far, our own and George Eliot. The Swift one will happen soon. Our AGM, fantastic video, which is on our website, and indeed we have the respiratory team in our workshop this morning, didn't we, who contributed to that, looking at how we'd managed COVID, and I'll say so far, because obviously we potentially enter a challenging winter. A couple of sections around the NHS financial regime and NHS performance management. On the financial regime one, I think one of the things that I'm trying to emphasise here is that a lot of the talk is about managing resources, managing the money in systems. Actually, the only accountable bodies are organisations like ours. So I think it's really important with the governance that we have around audit committees and quality committees that as the NHS transitions into system management, we don't lose the grip that individual organisations that are well managed bring to that. In the final paragraph, I talk about phase 3 letter, and I produced this report last week in time for the papers to go out. And lo and behold, on Friday, the phase 4 letter landed in all of our inboxes, the very last day of the month it was promised in. I will talk in more detail about it in my report next month, but I just thought it was, because it's such an important letter, I just mentioned a couple of things from it, if I may. I mean, firstly, this is so explaining phase 3. Phase 1 was the initial pandemic, how we managed that. Phase 2 was the restoration of urgent and emergency services to ensure that they were in place and accessible. And phase 3, which runs from now, is the recovery of services. And then we move into phase 4 from April next year, which is a reset for the NHS and probably a new deal and no doubt some new performance targets and a new financial settlement. But for this phase 3, which obviously therefore runs for the rest of this financial year, there are some really important milestones identified in the letter. It links to the money that was announced a few weeks ago now, an extra £3 billion for the NHS. That money ensured the continuation of access to the independent sector to help us to maintain elective throughput and cancer throughput, but also the backup of things like Nightingale hospitals. It also funds what will be a rather large flu programme this year, and the prospect of a COVID vaccine should that come along. But the flu programme, for example, will move from 3 million vaccinations to 5.5 million vaccinations, and therefore it's really important for us to ensure, particularly our healthcare workers, that we get a really good coverage of flu vaccination. The big milestone there relates to the recovery of elective care, so inpatient day case and outpatient procedures, and gives us a milestone of having 70% recovery in August, 80 in September and 90 in October. And that's compared to the same period last year. Many feel, me included, that the 90 ambition is pretty challenging. And we will obviously now be starting to look at our readiness for that. And I think there's probably just something about how we assure board on our preparations for that as we move forward. So this only arrived last week. There is, though, a financial incentive stroke penalty to achieving those milestones. We don't know the detail of that yet. It was one of those to follow notes in the letter, but we'll be looking at that. Obviously, most importantly, it's about accessing services and making those services available to our patients, but we'll try and understand the financial consequences of that. There's also some milestones around resetting our diagnostic services and also outpatients. With outpatients, there's an expectation we get back up to 100%, but within that, we will be of first outpatient attendances, just to be clear. We will be able to count digital virtual appointments in that, and obviously we've made some really significant steps, and indeed we touched on some of those in workshop this morning. And then finally, just the day before that landed, the much awaited people plan was also published. I'll talk about that a little bit more next month also. It's a plan that was initially produced last autumn, but it hasn't changed in any great way in terms of content for me, but the context has changed. So things like encouraging flexible working, home working, agile working is obviously important, but the well-being of staff and maintaining that, particularly as we've implemented some really good support arrangements for staff during COVID, in expectation that continues, and indeed continues into the future. The aim was always to create the NHS as the best employer, best healthcare employer in the world, or indeed the best employer in the world. So we will be looking at that, checking that the things we've already identified are still relevant, which I think they are, and I'll feedback next month on that. That's all, Chairman. I can't hear you, Chairman.
Sorry, schoolboy error. Questions or perspectives to Glenn. Andrew, did you have a question? Andrew, if you're asking a question, I can't hear you.
At our digital workshop, we learned the new word, you're on mute, didn't we, earlier?
Okay, Andrew, still.
He's there.
Is that okay?
Yeah. Yes, can hear you now, Andrew.
The report by Baroness Cumbridge and the issues of device and medicine safety. There is there's a long discussion in the audit committee some time ago about medical devices and medical equipment and the need for a strategy covering these issues, including the safety. We put it back into the system for developing, but it'd be good to know what progress is. And it's relevant because I think there's an issue a potential issue in the BAF around this, which we'll be looking at later. So I'm just wondering whether there's progress or whether you want Chair to bounce it back, just note it here and bounce it back to the audit committee.
I think if we can note it here, Andrew, and ask the audit committee to take it forward, but I think the issues around the report are very significant. So we will need to come back to it as a broad subject, given the learnings generally of the report.
So I'll make sure it's on the agenda for the next audit committee.
That would be great. Thank you, Andrew. And Chris, did you have a question? You're on mute, Chris, sorry. Okay, moving on then. Nicola, did you have a question?
Yeah, Glenn, obviously the performance management, getting back to normal, restoration is going to be really challenging, and a huge part of that is going to be the confidence of the public to come back to the hospital. And I've been quite surprised talking to people locally how that was actually much more prevalent than I'd realised. Is there any talk in the background or any help that we're likely to get with that, or how do we plan to help build that confidence?
I think that there will obviously be some national comms. There'll be some national comms obviously supporting flu campaign as well, and no doubt COVID vaccine campaign. So I think some of that will go on. I think we ought to be, though, doing some local comms on this. It's a bit of a double-edged sword in that as a result of COVID, there may well be some activity that's gone away that we wouldn't want to come back. Indeed, you know, there's been some discussions by some of the National Royal Colleges around urgent care to say, you know, some of those patients who used acute services when they could have used primary care. So we wouldn't want those people to feel that this is their best option, because it wouldn't be. It's their best option to access primary care. But obviously there's a big concern about the patients who should have been presenting. And if you look at some of our numbers, then there's a worry that patients who needed to see us didn't come. That's generally picking back up. If you look at urgent care, if you look at cancer referrals, it's generally back to normal. But there's obviously the potential of a number of people who would come late presenting to us. What we need to do is share with people the experience, because actually when patients have accessed our services, I've had loads of correspondence say we felt really safe. You looked after us this way. If you look at the protocols that we've got in place, particularly around outpatients, for example, it's a really safer than going to the supermarket in many cases. And I think that this really important message to get over to people, that the risks of not accessing healthcare are far greater than the risks of coming into healthcare under those circumstances. But we need to do some local comms.
Thank you, Nicola. Thank you, Glenn. Just keeping the pace going. Richard.
Yeah, just a similar point to Nicola, really, Chair. If we think back to those Elysian days before COVID, I mean, waiting times were going downhill nationally anyway, weren't they? It was tough then. So the enormity of this challenge, I'm not quite sure is appreciated by the public out there. So as Nicola has said, I think as well as kind of how we manage expectations upwards to our performance managers, there's an issue about how we manage expectations looking out to our own communities and public, and I think it would be great to do some work around that. Thank you.
No, I agree, Richard. I think part of the challenge, and Glenn sort of indicated in the phase 3 letter, the aspiration of getting back to 90% pre-COVID elective activity by the end of October is a great aspiration, but it needs to be regarded as an aspiration rather than a slam dunk deliverable. I think the challenges of that type of improvement trajectory are very real. So we'll come back to it a bit later, but managing expectations in the community, I think, is also important.
Yeah, probably, if I might just add to that, and the people plan emphasises this, the most critical thing for me is the well-being of our staff. And actually, I think we probably underestimate the impact of some of the things. And we had great example in workshop this morning with the team that responded very well, but the team all were exposed to some pretty challenging circumstances. So to suddenly say to those groups of staff, you need to go above and beyond to recover electives, and by the way, in this window before then winter starts to hit hard, we just need to look after people.
Absolutely. And then finally, Christabel.
Thank you, sorry, Chair. The comments about managing waiting times recovery at a system level, I just wonder what the implications are realistically for particularly our more rural residents and our Powys residents. Is there an implication there they might be asked to travel further afield?
I mean, for me, I think it is right that we use capacity to ensure that we deal with any potential inequalities. But that's probably more apparent in some other systems than in our own. I mean, there's not oodles of spare capacity in providers around us, but it does make sense across geographies like our SDP to make sure that if there is spare capacity and short waiting times in one part of the system, that we offer that to longer waiters elsewhere. So that's the intention, is to manage the problem rather than the entire waiting list. But I don't envisage significant changes in the pattern of delivery for us. We made some really good progress over the last 2 or 3 years on this. So obviously COVID set us back a little bit, but the continuing use of the independent sector will be the thing for us. But obviously that's just a mile down the road.
Okay, team, keeping the pace going. Let's move on to the integrated performance report. Jane, over to you, please.
Thank you. Just a few comments to kick us off, and relating back really to that discussion around the recovery plan. Obviously, the phase 3 letter only arrived at the end of last week, but we've been doing a lot of planning on that, and the plan that John and his team have been pulling together is predicated on, by specialty, anticipating that referral levels will be somewhere between 85 and 100% by the end of the year. But currently what we're seeing is our referral rates, although for cancer, they're nearly back to where they were. For other referrals, we're still at about 50% below where we were. So that really does have a profound impact on how quickly we'll be able to treat patients who've now been waiting a really long time. So over half of our waiting list, people have been waiting over 18 weeks. And obviously we started the year at about 80% of our patients were waiting under 18 weeks. But that referral rate is the thing that will drive how quickly we can drive down the waiting times. And so one of the things that we're looking at as a system, and we're talking to primary care colleagues about, is how do we jointly manage that waiting list, which is both for people who've been waiting a long time. So how do we know that that patient is safe? And so we're talking to primary care about that. But we're also talking to them about, so how do we manage the referrals that are coming in to the most, those with most urgent need? And are there some patients who can wait a little bit longer out in primary care before referral? So, and I think that will be a test of how well we're working as a system between primary and secondary care, to how well that risk is managed in that widest sense of the word of across those referrals and those waiting times. The only thing I'd really like to say other than that is that it's really good to see the improvements that have been made in our infection prevention measures. In a sense, you'd expect it all to be absolutely excellent at the moment because of the COVID experience, and that's certainly been true, and that's what we're seeing. We need to keep that up as we go into the future, because we know that's one of the things that the CQC felt that we hadn't concentrated on enough when they came and visited us. So really good to see that. But in terms of our VTE performance, again, we're really well aware we need to get back on top of that again, and it's something that Lucy and David are really concentrating on. Other than that, those are just my opening remarks.
Okay, thank you very much, Jane. Are there any immediate questions to Jane, or shall we move on to the detail? Thank you, Jane. So over to you, Lucy, please.
Okay, so VTE is the deep dive this month, and I'm going to hand over to David to talk to that in a moment. But just before I hand over to David, 3 points from me. Just to say that the CQC had their supportive conversation with us last week in relation to the Infection Prevention Control Board Assurance Framework, which was presented to board last month. And we've received their review letter back that says that they're confident that we're compliant with all the elements of the BAF that we were required to self-assess against. So they're confident with our self-assessment and recognise the work that we're doing to improve antimicrobial stewardship. The second thing I just wanted to point out was just the really good news around reduced agency reliance and seeing that Thornbury reliance, so the expensive agency, reducing significantly again this month. And then the final thing from me, because it was difficult to get off the ground, but we have now, is around the flagging of learning disability patients on our electronic patient records. So by having a flag that alerts our staff to the fact that an individual may need some reasonable adjustments in order to provide personalised care to that individual. And earlier this year, we only had 140 learning disability patients flagged on our system. So we've now got 549, which means that those individuals are able to receive the right care early on in their journey with us, and also have access to the specialist team when they need it. And I'll now pass over to David for VTE.
Thank you, Lucy. You're on mute, David.
Thank you. Can you hear me now?
Yes, we can.
Okay. So venous thromboembolism remains a priority for the Trust for 2021. There are two main strands, which are the assessment and prevention with thromboprophylaxis for patients that are coming into the hospital, and for those patients who do go on to acquire a clot, a thromboembolism, are there any lessons that we can learn from it? So just a little bit of history. This is something we've struggled with for several years. In terms of the risk assessment, if I can take you back to 1819, we were performing poorly. we reassessed the patient cohorts that we were assessing, and that wasn't an attempt to manipulate the figures. What we actually did was increase the number of cohorts that we brought into the assessment procedure, aligned to the NICE guidance and the NHSE guidance, and we were performing better than in areas that we previously excluded, and so we started to we were performing better than we thought we were. We developed ward level escalation procedures, and we developed an outreach support, because it was still a very manual process, as it remains to date, really. But we developed an outreach support from the quality and safety team to the wards, and that led to some improvement. In 1920, we developed daily reminders from the ward clerks to the clinical teams, which could then ensure on the ward rounds that patients had the VTE risk assessment performed. We broadened the number of clinicians that could perform the risk assessment. They were eminently able to, such as advanced care practitioners and senior nurses, and we provided ward level data to each ward that could then be discussed on the ward huddles, and local improvement plans developed. So performance in January, February, so pre-COVID this year, was 95% for the first time since 2017. That did then dip during COVID, and we're currently, well, for June, we're at 92%. We are aiming for over 95%. For the future, I'm excited. I'm as excited as I get about EPMA and its association with VTE risk assessment, in that we won't be able to prescribe without a risk assessment being performed. And really, for the trusts that are performing highly in this, it's these electronic systems that takes out the human element in it, remembering to do it, should I say, that really makes one sustainably achieve the 95%. The EPMA program, so that's the e-prescribing program, is starting to be rolled out in October this year. With regards to hospital-acquired thrombosis, if I could just briefly outline the process that we have, which is, again, essentially manual and thereby very difficult to keep at a sustainably high level. We have an individual that identifies patients that have undergone or suffered a VTE during their hospital admission, and that's via a daily assessment of the radiological records. Notes for those patients that have acquired a thrombus during that admission are then delivered again manually to the consultant. The consultant then assesses using a pro forma, so a standardized assessment process, whether the VTE was essentially preventable or otherwise. In other words, had appropriate thromboprophylaxis been undertaken, etc. That pro forma is then discussed at a VTE panel, which agrees or otherwise the preventability, and if it is deemed to be preventable VTE, then it is declared a serious incident and recorded and managed as such. When we assessed the process, there were delays at every single one of those levels, which is why our performance was nowhere near as well and nowhere near as good as we would have liked. Subsequently, we've streamlined the provision and the alerts to consultants. We're now providing consultant level data on a very regular, so monthly basis. So individual named consultants, we're outlining to them that they've got 2 or 3 potentially VTE assessments to make, and these are then discussed at our finance performance meetings. And we've also increased the capacity of the VTE RCA panel. We've doubled the amount there. So we are seeing an improvement in the VTE hospital-acquired process as well. I think that's probably all I want to say, Chair.
Thank you very much, David. Questions or perspectives to Lucy or David? Andrew?
Yeah, I was just interested, well, it's a question, is there a sort of trust-wide issue with the exposed pipework incident? Are people being encouraged to put that into their risk assessments? It's on page 28.
Andrew, was that in the relation to a patient who fell?
That's it, yeah.
So that was a specific issue in one of our community hospitals where it was older estate. The same problem doesn't exist here because the majority of wards within the PFI have hidden pipework.
Okay, thank
the
you,
other
Lucy.
community hospitals are say okay as well, are they? Any issues in any of our facilities?
Not that I'm aware of, but given that you've asked a question, let me double check.
Okay, come back to us on the matters arising. Thank you. And any other questions to Lucy or David? Grace?
Unmute. Thank you, Chair. To Lucy, it's great to hear about the huge progress that's been made once the trust began the process of flagging patients who have learning disabilities. I'm just wondering what's happening, if there's any thought to flagging patients who are autistic. The National Autistic Society has got some great guidance to health professionals about working with autistic patients that differs quite significantly from working with neurotypical patients. And there's also an interesting study out of the Internal Medicine Journal in the US in 2013, which looked at the differences. So I'm just wondering if we've thought towards that at all.
So we use our flagging system for a number of reasons. So patients who are at high risk of falling, who have a particular infection, learning disability, hearing, sight problems. So flagging's used for anything where an individual may need their care modifying or a higher level of observation. The Learning Disability Service is provided by our community trust through a service level agreement, and that team are responsible not only for patients with learning disability, but they also support patients with or individuals with autism and other factors. So there will be individuals flagged on our system that have autism and therefore have differing needs to others.
Just as an aside, I mean, some of the most talented people I've ever worked with in my life have been on the Asperger's scale. So I always worry when, and I know you weren't doing this, Grace, sort of bucket autism in as a disability. For me, some of the most able people I've ever come across, as I said, are on the Asperger's scale. And any other final points? Please come off mute if you have. Okay, thank you very much. So we move on then to activity. John?
Thank you, Chair. Just first of all, just to point out that the report's changed a little this month. I hope the board find this helpful. It certainly helped me to write a more a better narrative. I feel that relates more to where our KPIs are moving around. So I hope you find it helpful. I welcome some feedback. Moving on to the content, really just a few points. Cancer, I think, has been covered already in the conversation today. You can see from the graph there quite clearly the fact that the way RFL's dropped up and they've climbed back up to almost nearly levels, normal levels rather, and we have managed to keep pace with cancer treatment largely. We do have a few more longer waiting patients, but we are starting to tackle those now. So I think what we should all be concerned about, certainly locally, regionally and nationally, is the screening programmes will start again in September. And clearly there's a lot of concern about patients that may have gone undiagnosed, and so we're with that clinically and operationally in terms of being able to respond to their needs when they present. RTT referrals, Jane's already talked about that. You can see from the graphs there that they remain really quite low. Activity, however, sort of elective activity, inpatient day case activity is starting to climb up, and we've got to 50% in July, and we're expecting quite a sharp increase in activity, and we'll talk about that later on in the private session. Outpatient activity, however, thanks to our large proportion of patients being seen virtually, is a lot closer to what it would normally be and continues to increase week on week. I won't go through the referral to treatment. Yeah, outpatients, the virtual component of outpatients, I haven't put in the report, but I saw it yesterday. We're down a little bit, but that's because our face-to-face has increased rather than our virtual has decreased. So I think it will settle. I think nationally they're thinking 25 to 30% when you're working within normal circumstances, but we're still at that 46%. So it might be natural variation, or it might be a trend as we've seen more face-to-face patients. 52 weeks, can't really not mention that. Obviously, that number is quite large within this report, and it's larger still now. It's we're over 200 English waiters and nearly half as many again for Wales. Currently, that number will continue to climb for a few months yet. So that could get quite a bit bigger. We are trying our very best to treat people clinically first, clinical urgency first, and then chronologically. But as our services start to increase, then we'll be able to start to tackle that. Diagnostic, we started to get on top of some of the diagnostic stuff. As you can see there, the over 6 weeks has sort of plateaued for the last few months, so it hasn't run out of control. There are a few hotspots we need to worry about. CT, particularly at the moment, we've got some local problems in one of our scanners that's due for replacement at the end of this month, but that will take 20 weeks for that work to be completed for both scanners to be replaced. So there are some concerns around CT. We are looking for regional support to see if we can help with that, particularly around CTC. And endoscopy is a national concern in terms of the way productivity has been impacted by COVID precautions. Our teams are working really hard and actually doing a lot better than others in terms of getting as close as they can to normal activity, but still significantly below what we normally would do. ED, our numbers are going back up in terms of activity and conveyances. They're very variable across the week. So overall for the week, we're probably down on what we were, but on our busy days, we're seeing numbers at least as high as we would have seen this time last year. The gap between our admissions currently and our admissions this time last year is closing week on week. So I think it's about 35, a rolling 6 week average as of Monday for the previous 6 weeks is about 35 patients different from the same 6 week period last year. And there's not a lot in that. I won't go through. Just to pick out really, same day emergency care is something that it's pleasing to see that coming back up. We got back up to mid 30s. The team are very focused on getting to above 40% very soon. There's a new process being put in next week to help do that, and we'll focus on that for the rest of the year because clearly that's an important piece of work. So we intend to get to over 40% and stay over there. And bed occupancy, really, it's very variable. It has come back up. We're at mid 70s as we talk today. Not all of those beds are available for us. Some of them are locked into elective pathways, the green pathways. Some are locked into COVID precautions. So it's getting a bit tighter, but it's certainly not reduction in admissions that's driving our bed occupancy. It's the improvement in discharge, the improvement in length of stay, and reduction in electives that's driving that bed occupancy at the moment. But we need to keep that as low as we can, for as long as we can, to improve flow, maintain flow. That's it. Thank you.
Thank you very much, John. Very clear. Questions and perspectives. Richard first.
Yeah, thanks, John. John, we've previously discussed the improvements that we've made to discharge arrangements because of COVID. And I was wondering, how optimistic are you feeling about how we can sustain those improvements, given that the financial climate is becoming less generous? We've got to reintroduce continuing healthcare assessments from September and so on.
Yeah, I remain optimistic, but concerned. If we do go back to sort of not using trust assessment, not following a discharge to assess process, and that's the real key. The discharge to assess has been the real key. Nobody waits for an assessment now. They go to the most appropriate place, get assessed in a much more fitting environment, and hopefully then go to the best environment for them. If we lose that, then we're afraid we will backslide. I mean, we've checked on numerous occasions. We've done audits, snap audits. We knew we carried 50 to 60 patients in our hospital, our acute hospital, and probably in our community hospitals, the same volume of patients that didn't need to be in that care setting. Today, we've got 8 in the acute hospital.
Yeah. No, as you say, it is a worry, John. Thank you, Richard. And Glenn?
Yeah, I mean, despite the reintroduction of funding panels, it is good that there is a kind of national rollout of discharge to assess with the 6 week protocol. So that's a positive in it. I was just going to turn to the issue. So one of the things around recovery is the need to hopefully do so by addressing some of the inequalities of access or outcome for our patients and communities. slight concern around digital in that it may introduce new inequalities. So I think as we do that, we need to be careful that we look at the needs of the patient rather than the needs of the clinician. I know for many patients it's a much more it's an easier way to access the service, but for others it will be something that they're not so comfortable or able to do.
Yeah, we are looking, if I may, we're looking at sort of setting up a hub approach within the primary care networks where we actually find a space that's enabled and perhaps with some support, so that people that don't have the technology or are not comfortable with technology can go in there and still access virtual appointments in the same way as everybody else, and hopefully access their blood tests and their x-rays, etc. So that's a piece of work we're trying to rapidly do now, see if we can help overcome that problem.
Okay, thank you, Glenn. Just a couple of quick questions from me, John. I would like to find a way, and I'm encouraging it at Swift and George Eliot as well, for us to assess cancer performance and how we compare across the Midlands. So if we can find a way of doing that, and maybe reach out to Helen Lancaster at Swift as to the way she's sort of informing some of the discussions we're having there on that. And the second thing is, in terms of the 70, 80, 90 trajectory that the phase 3 letter lays out, we'll obviously be discussing it in more detail later on, but at the moment, what do you think your core view is as to the way our percentages will work out?
We're going to struggle to get to those volumes because it's last year's activity. We were going fairly hard at it last year, so I think we're going to struggle. That said, I think we can reach our targets of what we think we need to do in terms of referral. So there's a bit of sort of what's the most appropriate thing for us to do. So we think at the moment, our clinical teams think that we can do a level of activity that meets demand, so we can hold our position and begin to improve it for some specialties. So okay, I think there's a challenge in terms of 100% and 90%, etc. And I think we won't hit the September targets, but we'll get close in some elements. I've got some graphs later. I can show that in more detail.
Okay, I just want to manage expectations amongst members of the public, and just keeping the pace going. Jane, did you want to make a point?
Yeah, it was just going back to the discharge pathways, and one of the other pieces of work that we've started, and Howard's leading on with colleagues in the local authority, is to understand what the financial impact of those pathways has been. So, you know, we know we've had much lower lengths of stay and occupancy in the acute. There is a value to that. We may not be able to take cash out today, but we need to understand that. But what has been the impact on spend in particularly care homes, things that are being funded, what's happened to the rate of admissions to care homes, what's happened to the numbers of patients who are going directly home. So there's a piece of financial analysis that's being done that I think from right, we were hoping to get done by sort of middle of September, I think, weren't we, Howard?
Can't hear you, Howard.
He was nodding.
Okay, great.
I was nodding, yeah.
Well nodded, Howard, thank you. Okie dokie. Colleagues, happy to move on? So, Jeff, over to you on workforce.
Well, thanks, Chair. In terms of the workforce report, as you can see, we've made some good progress over a number of key workforce performance indicators over the past few months. The one area that we're still working with managers on is the performance appraisal. So we will ensure that over the next few months, certainly before winter kicks in, we do undertake the outstanding appraisals as well. Over the past few months, because of COVID, we've actually been trying to focus on the health and well-being, provision of health and well-being interventions for our employees in line with our compact. So we have the health and well-being compact in place. And I have made contact with the University of Derby through Frank. So Frank sent me, made an introduction to the University of Derby, who will be undertaking a pilot project on mental health and well-being support for employees going forward over the next 24 months. So we're going to be trying to see how we can work with them as well. In terms of risk assessments, which is important, we have ensured that all of our BAME staff have had the chance to do the risk assessments, and also all those who are deemed to be at high risk. We've now extended the risk assessment process to all employees. So certainly hopefully by the end of August, we anticipate that everyone would have had the chance to undertake the risk assessment. In terms of the HR reports, obviously I'm going to be refreshing that over the next few weeks, and I intend to bring a refreshed report to the board certainly within the next few weeks.
Super. Thank you very much, Jeffrey.
Thanks.
Questions and perspectives to Jeff? Andrew?
Yeah, it's just a comment really. If you compare June 19 with June 20, it's really impressive. It's establishment increase of 130, but a vacancy reduction of 100, I think it is, something like that. All driven by recruitment. I think it's really good.
What did Napoleon say? I'd rather have lucky generals. And so, Jeff, I think the timing of your arrival has been superb, being able to display that type of improvement. Thank you for pointing it out, Andrew. Any other questions or perspectives? Colleagues, happy to move on to the money? Well, we continue to live in different times with the money. Howard, do you just want to brief us on where we are?
We do indeed. So just a few points I'd want to draw out today. So again, at month 3, we reported break even. We required a retrospective top up of 922,000. This is almost doubled what we had previously, and this is because of the new way of accounting for PDC dividends, which we had to add in for the first time this month. Underlying operational expenditure continued to be lower than previous, but expenditure on pandemic-related items increased compared to the previous month. And I was just bringing out for a note that this trust has so far spent 4.4 million specifically on COVID to the end of June. And this was about 7.7% of operating expenditure compared to the national average of 5.3%. As Lucy has already mentioned, agency nursing has reduced. We did talk about this last month, and I'm pleased to see the relationship now between the actual numbers and the costs coming through. And we also saw a significant reduction in medical agency last month, primarily due to the changes to requirements for consultant cover, where a number of people either came back or we had substantive people starting. I do want to raise one item of caution, though, because as Glenn mentioned in his report, the new finance regime is shortly going to hit us. It's been they've been promising allocations for the second half of the year for a month now. We've done some initial planning, which does indicate a likely pressure on the trust, but that does all depend on the actual income that we get assigned. I mean, we've built in currently an assumption on income levels similar to those we've had for the first 4 months of the year. And the second thing is what decisions we take about funding Plan B, which is the restoration that has already been talked about. But I expect to bring a financial plan either to the next board meeting or to the one after that, because it will apply for the second half of the year. My final 2 points were relating to capital. So far we've spent 5.4 million in the first quarter, 3.1 million of which was on the Hutted water replacement, which as has already been mentioned, is going up rapidly at the moment. And we have also received an extra 1 million towards critical infrastructure. This was money which was announced about 2 weeks ago, and we've got £1 million of that. So we're extending our backlog maintenance program. So those were the key points. Take any questions.
Thank you very much, Howard. Glenn, first of all.
I think that nursing run rate chart on page 61 of the pack is officially my favourite chart across the group at the moment. So well done to everyone for achieving that. I'll be tweeting it later.
Thank you, Glenn. And I think you had a comment, Frank.
It was referring back to what Jeffrey was saying about the mental health community approach.
Yeah, can we maybe raise that later if need be, Frank? I've seen the comments, but
I just pushed a note through.
Yeah, thank you. And Chris?
Thank you. A comment really, a congratulation that your invoice processing has continued to be really good. And I think that sends a really positive message in difficult times. And just a question that could be taken offline is on page 60, there's 2 references to private patient income. Maybe I've missed this, but I've never been aware of PPI before. I'd be interested to know the extent of that, but as I say, offline.
Okay, Howard, are you briefed on that, or do you want to answer it through the minutes?
I'm not able. Yeah, I prefer to come back to that. I don't have the full sort of quantification of that at my fingertips.
Okay, so can we handle that through the minutes so it's just totally transparent? Any other questions on finance? Okay, thank you very much. So we'll move then on to the digital programme update report. As I mentioned earlier in my introduction, we had a long session on our long-term digital strategy, but this is the work that's going on at the moment. Howard, anything you particularly want to emphasise?
Well, not really, to be honest, Chair. I was going to take the report as read. I think that I hope that my opinion section really summarises it effectively. But basically, we are continuing to make progress on all schemes and all projects at the moment. And I mean, I would just also highlight that I have extended the scope of the paper to cover most of the, if not all of the projects. You know, it began initially as an EPR paper, extended to EPMA, and now I've included e-rostering and other projects. But no, I'll take it as read and answer any questions the colleagues have got.
Thank you. I had some really great work being done by the whole of the Wye Valley team. And again, we heard about that, and it's been enormously important during our management of the COVID crisis. Any questions from colleagues? Chris?
Thank you. Under EDS, you talk about a stakeholder group. Can I ask, are patients and GPs being involved in that?
I think not. I think an internal stakeholder group, to be honest, Chris. But I will get back to you on that to confirm absolutely.
I would urge it.
Okay, thank you.
Okay. And any other questions or perspectives to Howard on the digital update report? Okay, thank you very much. Then we've got the Freedom to Speak Up report. Jeff, anything you'd particularly like to pull out?
Just to say that the report just shows that the process we have in place is working really well, and we are encouraging staff to speak up because we welcome those opportunities. We see those as how we can enhance the service we provide and also ensure that staff work in the best possible working environment. So we have a system in place on a monthly basis. We're reviewing things, working closely with the Freedom to Speak Up Guardian. The report outlines some key lessons in there and activities planned for the rest of the year. So I think we've got a good system in place, and we continue to encourage people to speak up.
No, absolutely, Jeff. And I would just endorse that encouragement. If any members of staff, obviously there are good internal processes allowing you to anonymously speak up, but with Sue Pike and Chris and others, I really would encourage people, if they've got an anxiety, to pick it up. Any questions to Jeff on the Freedom to Speak Up report? Okie dokie. I apologise, I missed the mortality report. So if we can just go back to that. David Mowbray?
Thanks, Chair, you're forgiven. The HMSR remains below expected levels. Shibby's increased slightly to 104.5, and that's mainly reflected in the community hospital, which I'll say a little bit about later. Crude mortality is returning to more normal levels post the COVID surge. Some good news about the mortality outlier groups. I think the board will recall that I was concerned about the increasing levels of mortality in our patients with fractured neck of femur. We're continuing now, after a significant amount of focused work, to see reductions in these rates. We had a very useful peer review from our SWIFT colleagues, which has directly led to really significant improvements in getting our patients to theatre. So when we were a few months ago starting this work, our patients were taking 36 hours to get to theatre with a fractured neck of femur, which was 2 hours above the national average. Post the peer review process and introduction of what we call the golden patient, currently we're recording 24 hours, which is actually 10 hours below the national average. So I look forward to this translating into real significant reductions in mortalities for these group of patients. Community hospitals nationally are now getting reported separately. So all three of our community hospitals are now nationally visible on the SHME statistics. And we've always been cognizant of treating these separately and inquiring as to why there was some variations in mortality. I'm glad to say that we have now got a system for peer review of the deaths in the community hospital. So very shortly, GPs that are manning one community hospital and senior sisters will be reviewing the deaths in their buddy community hospitals. The bereavement services are described in the report. We've seen significant improvements there. And the improved identification for patients with learning disability, which has already been alluded to. And lastly, it's our first attempt at a local real-time dashboard, as much as we can make it real-time, for perinatal mortality. It's not where I want it to be. I want it to be reporting on a rolling deaths per thousand, as per national reports, but it is the first time we've ever had this as a trust, and I don't think there's many trusts actually have this in real time. We've already converted it to SPC charts. I think the shapes that you see in the charts on there won't change, but the format of it will, to make it more interpretable. I think that's probably all I want to say, Chair.
Very comprehensive. Thank you, David, and great to see that innovation. Any questions or perspectives to David on the mortality report? Okay, so moving on then to the board assurance framework and high risks. Erica.
Thank you, Chair. Just in terms of the administration of the BAF, in response to an audit report that we had last year, the BAF is now hosted on Datex, so it looks a bit different, and I acknowledge we haven't quite got the formatting right for the BAF and the high risks, but we're working on that with the Datex team. But by hosting the BAF on Datex, our risk management IT system, it means that we can really do ward to board on the supporting actions and mitigation measures that are on the system to support our own risk management of the BAF. So the BAF has been created this year in discussion with the exec directors, and it's all those risks to us achieving our strategic objectives. So that's the first attachment. The second attachment is the high risk report, which goes through the executive risk committee of all our high risks that are over 15, so in the high risk category. Of those, I'm pleased to report that a number are you won't see going forward, with the actions are due to conclude, which will reduce those risks significantly, but I stand by to answer any questions.
Thank you very much, Erica. Questions or perspectives to Erica on the BAF and the high risks report? And obviously the danger of a second spike and a local outbreak of COVID-19 is the thing that for members of the public, we are all very cited on. Colleagues, happy to move back to the patient experience call to one report. Over to you, Lucy. Thank you.
Thank you. So I'll take the Q1 report as read and just talk through a few points, if I may. So we've had a lower number of complaints during this quarter, but I suggest that that would probably coincide with reduced activity during the pandemic. During COVID, we implemented a new process that we want to stay with us as business as usual, which is aiming to resolve concerns or complaints raised by our patients or members of the public in a more timely manner, and avoiding entering into a formal process and resolving those complaints sooner rather than later. And that's worked really well, and the divisions have really engaged with that process in terms of resolving concerns in a timely way. And so, as I say, we want that to become our new norm. We amended our policy for complaints management to bring that in line with George Eliot and South Warwickshire Foundation Trust. So we now aim to respond to any complaint entering into the formal process within 30 days. And you can see within the report, we have got some improvement against that standard, but still some way to go to get to a level of performance that we would want to achieve. Communication and discharge remains top themes in relation to the themes within complaints from both our patients and their families. And when you look at that, that triangulates with the National Inpatient Survey results for Wye Valley Trust, where patients don't always feel that they're engaged and communicated with well, either during their stay or at the point of discharge. Friends and Family Test was suspended nationally at the outset of the pandemic and remains suspended. There is some suggestion that it may well not even recommence, but we're aiming to develop a local survey that we use on a much more frequent basis so we can collate real-time feedback. The National Emergency Department Survey is due to commence for patients who are attending our emergency department during September. And then that's to be followed by the National Inpatient Survey for patients who spend a night or more in hospital during the month of November. And we've got an improvement plan around the results of our National Inpatient Survey from last year. And some of that is work ongoing in the emergency department and within our inpatient wards to make improvements in responses to that. Throughout COVID, we had a tremendous support from volunteers, and interestingly, many of those were new volunteers to our services, because many of our longer standing volunteers either needed to shield during COVID or chose to shield and self-isolate. And we'll be hearing a board story next month from our pharmacy volunteers. My Associate Director of Nursing has set up a vulnerable persons group to start to address some of the practical aspects of caring for individuals who are vulnerable. We'll see the outputs of that in future quarterly reports. And then given the findings of the National Inpatient Survey results for Wye Valley, which I alluded to in last month's quality report, I'll be leading a board workshop next month on the detail of those results. It was delayed by a month in terms of feeding into the board workshop because we've asked for some detailed sort of ward level breakdown of the findings in order to feed into that workshop next month. So more to follow on that next month. I'm happy to take any questions.
Thank you very much, Lucy. Just before I open it up, there's some absolutely fantastic work undertaken by members of your team pre-COVID on reaching out to, for example, the homeless community and other vulnerable adults. So really, really proud of that team. And the second thing is obviously just again to put on record the recognition of the board of the enormous upset and stress of being separated from loved ones who had COVID, from members of the family, and the enormous stress it put on our frontline teams in endeavouring to help. We heard that again in the AGM video that members of the public may have seen, but also on the workshop presentation that we had this morning. So all of that fully recognised. The questions and perspectives to Lucy. Frank, do you want to make a point?
I've just posted a note that the thinking of you, the whole compassion of the nurses, I'm actually witnessing it being talked about in the community in several places. It really has transformed some images of the service that's provided, and it showed through in the video this morning, didn't it? Which is available online and is a magnificent example.
Absolutely, thank you, Frank. A question from Andrew?
Yeah, two questions. One is, I suppose I didn't get a sense of confidence that the 30 days would be met from the report, and I just, maybe you could explore that a bit more. And the other question is one I think we probably raised before, is what the position is for translation into Welsh if people request it. I don't.
Lucy?
I wouldn't think the Welsh is very I wouldn't think there's a lot of people requesting it, but there could be.
There's in relation to the 30 days, we've certainly got data currently showing that we are achieving that in month. What we've got, and the reason performance is such poor, is a backlog of complaints that are quite old that we're clearing, but that backlog is reducing. But we can provide more detail on that next time, Andrew. And you're right, the demand actually for translation into Welsh, there isn't a high demand out there, but we are able to access that if required.
I certainly know from when I was chairman at Oswestry that the cost of changing all of the signage into Welsh and English was substantial, almost £250,000. So unless the demand is there, I think it's we would need to recognise the cost of doing that. But clearly, translation services are available. And any other questions or perspectives to Lucy? Okay, thank you very much. And thank you for your question, Andrew. Moving on then, I'll take as read the Foundation Group Strategy Subcommittee Annual Report. Any questions on that? Okay, duly noted. Thank you. And thank you, Richard, for your continuing work on that subcommittee. We'll then move on to the committee summary reports. And unfortunately, we've had to lose Chris for a couple of minutes, but any questions on the Quality Committee at the 25th of June, Lucy, that we should be aware of?
No, I'll just take the report as read, but I'm happy to answer any questions.
Okay, any questions on that report to the 25th of June? And then on to the 28th of May. Anything in particular to pull out, do you think, Lucy, or just take as read?
Take it as read.
And any questions on the Quality Committee, the 28th of May? Any other business, therefore, from colleagues? And I've just been informed that we have no questions from members of the public. So just to say again, as we close this live stream board meeting, we are going to continue to use this format to have our board meetings, as we believe it's the safest way to avoid cross-infection during COVID. I would strongly encourage all members of the public to continue to socially distance, to wash their hands as much as possible, and to wear a mask when going out in public. COVID-19, as many of you will be aware, is a really deeply nasty disease, and we all have our part to play to try and manage the current situation. And as you're aware, and from what you've heard again this morning and at the AGM, the executive team and most importantly, the frontline teams, the nurses, the doctors, the cleaners, the catering staff, everyone involved in the hospital are going beyond their call of duty to look after the people of Herefordshire. And as a board, we're incredibly proud of them. Thank you very much. Take care. And I look forward to seeing you again on the 3rd of September. Erica, if you can please stop the live streaming.